My name is Eamon Quigley, and it's a great pleasure for me to welcome you to the 8th annual Inflammatory Bowel Disease Lecture, which is brought to you thanks to the wonderful generosity of Dr. Carl and Lynn Schmulin, who have been so generous initially in supporting this on a year-on-year basis, and now actually giving an endowment which will endow this lecture in perpetuity. And for that, if we had an audience here, I would ask you all to get up and to give applause to Carl, who thankfully is here with us this evening. So this is our annual IBD lecture and is a flagship for our Fondant IBD program, which is led by Dr. Binsi Abraham. And I will now ask Binsi to come introduce our speaker for this year's lecture.
Well, welcome, everyone. I am saddened that we couldn't have our lecture here in person with us and be together in a large auditorium in person. However, I'm so happy to introduce our speaker and lecturer for this year, this Dr. James Lewis. He goes by Jim. He received his undergraduate degree from University of Virginia in interdisciplinary studies and then went on to do his medical training at the University of Pennsylvania, where he also received his master's in clinical epidemiology, and he's currently the professor of medicine and epidemiology, associate director of the Inflammatory Bowel Disease Program, and director of clinical research in the Division of Gastroenterology and Hepatology at the Perelman School of Medicine, University of Pennsylvania. He's currently the lead scientist for the Crohn's and Colitis Foundation of the IBD Plexus Research Program. His work has been funded by the NIH and numerous foundations, and he's a recipient of the Sherman Prize for Excellence in Crohn's and Colitis Research and the Crohn's and Colitis Foundation Clinical Science Award, as well as other educator awards and teaching awards. So I'm so excited to introduce and have Dr. Jim Lewis present our 8th annual Dr. and Mrs. Schmulin IBD lectureship on a very important topic that we receive from our IBD patients, probably the most important question we receive in our clinic on a day-to-day basis, which is really the question of, is there a best diet for patients in inflammatory bowel disease? So welcome, Dr. Lewis. So looking forward to hearing your presentation.
Thank you so much, Binsi and Eamon, and mostly to the Schmulins for sponsoring this opportunity. I really wish that I was able to be with you in person, but hopefully we will have a great get-together through the beauty of Zoom. So let me get my screen shared and we'll get going. I'm assuming that you can see my screen now. So let me start just by commenting briefly. I don't think that I have particularly relevant conflicts of interest, although the closest to that would probably be some research support from Nestle Health Science, and I've done a little bit of consulting for them. The rest of this is lots of other companies related to IBD work, but probably not particularly relevant to today. You know, as Binsi mentioned, our patients really care about diet and IBD and are interested in what they should be eating. There's a lot of other reasons that we should be thinking about diet and IBD. And one of these is that maybe diet is part of why people get IBD. We know that immune-mediated diseases, IBD, as well as other diseases, so like rheumatoid arthritis, lupus, etc., are increasing at rates that are way too fast to be explained by genetics. So there has to be some environmental exposure here. And if you just take a look at the worldwide incidence of IBD, it's obviously not equally distributed around the world, and this has led to lots of hypotheses about a Western sort of diet or other Western life exposures contributing to the incidence of the disease. Interestingly, though, if you look carefully, it almost doesn't matter where these studies have been done. This was a systematic review that looked at studies, two different ones, that looked at studies of incidence rates in different populations. And you don't need any fancy statistics to see that almost all of these lines are going up over time, consistent with a rising incidence in almost every study over time. Now, some of that is almost certainly we've just gotten better at making the diagnosis. We have more CT scans, more colonoscopies, et cetera. But I do think the rise in all of these other immune-mediated diseases that don't take fancy technology to make the diagnosis suggests we probably are globally seeing a rise in immune-mediated diseases. So why does that connect to diet? I think that science tells us that something in the lumen of the gut is driving the inflammation for patients with Crohn's disease and ulcerative colitis. I'm putting this slide up not because I'm going to go through a detailed discussion about the complexity of how the intestinal epithelium works, but just as a reminder of what an incredible space this is, where we have, this monolayer of cells combined with immune-mediated cells and a mucus layer, all designed to help us figure out what's friend or foe. And, our epithelium of our guts exposed to, a huge variety of external exposures, ranging from bacteria and fungi and lots of small molecules, many of which come from food. The other thing I want to remind you of is more so in Crohn's disease than in ulcerative colitis, that these are sort of progressive sort of destructive disease. And along the way, at least 50% of people with Crohn's disease historically have required surgery. And the most...
I was like, there?
Oh, are we okay? Okay. The most common of those surgeries is an ileocecal resection. And this, as you know, can be done either with a primary anastomosis, or it can be done with a diverting ileostomy. And sort of an interesting phenomena is that Crohn's disease tends to recur at the same place as it was originally. And so when people have had surgery, it tends to recur right at the anastomosis or just proximal to the anastomosis. But what's particularly interesting is that if people have a diverting loop ileostomy at the time of surgery, allowing for greater time for the anastomosis to heal, you typically do not see recurrence of Crohn's disease until that diverting ileostomy is reversed. This was perhaps best demonstrated in what I always consider the most elegant study of 3 patients that I ever saw, where Geert de Haans and his colleagues took 3 patients who had ileocecal resections, diverting loop ileostomy, did a colonoscopy, went in and showed that everything was totally healed, then took the effluent from the ileostomy, put it in a syringe, and squirted it in the downstream loop for a week, and then repeated the colonoscopy. And lo and behold, all of these people now had evidence of inflammation, suggesting that there was something in the lumen of the gut, that effluent that was coming out of the ileostomy, that was driving the inflammation. Now, there are lots of things in that effluent, right? There's digestive enzymes, there's bile acids, there's bacteria, there's food, there's other external compounds that we're consuming. I can't tell you for sure which one of those things, or if it's only one thing that's driving the inflammation. But what I would say is it's sort of compelling that there's something in the lumen that's driving it. And the easiest of all those things that are in the lumen to change is what we're eating. So with that as a little bit of background, we can look at some of the epidemiologic studies that have been conducted over the years to see whether some of the environmental exposures might explain really what's causing IBD. And I could give a whole different talk that went through a whole lot of different environmental exposures, but let's just focus on the food-related versions of this. And so one important observation is that if you look at immigrants from regions with low incidence of IBD who move into a region with a high incidence of IBD, in general, the first generation immigrants continue to have a lower incidence of IBD, but their offspring, the second generation immigrants, tend to have an incidence of IBD that's about the same as the region that they moved into. And you can interpret that a couple different ways. One is that the first generation immigrants didn't really completely immerse within the culture of their new environment, and that's why they didn't seem to take on a higher incidence rate. Or alternatively, maybe it's early life exposures that are particularly important in driving this higher incidence rate when you move to high incidence regions. Well, we think really about food. Everybody's first diet is either being breastfed, formula fed, or some combination thereof. Not surprisingly, there have been lots and lots and lots of studies that have examined the association between breastfeeding and your risk of going on to develop Crohn's or ulcerative colitis. These are summarized here in a relatively recent meta-analysis. And if you look carefully at these, you can see that the pooled estimates shown at the bottom of the slide would point to the concept that the longer you breastfed, you had a slightly lower risk of developing Crohn's disease or ulcerative colitis. And typically this is pediatric onset of these diseases. This is not to say that if somebody can't breastfeed, it's a disaster, but it's just another incentive for moms to breastfeed, particularly those who actually have IBD and may be sort of self-conscious about this, to say this is something that you can do that may reduce the risk of your child developing IBD. Well, after we're weaned from breast milk or formula, where does our diet go? Sadly, most of it goes to Taco Bell and McDonald's, as best I can tell. Based on these data from the National Center for Health Statistics would suggest that about a third of us consume fast food every day. And then there's lots of other really ultra processed foods that we're regularly consuming as part of our diet. And there's been a lot of work that has gone into asking, well, what about these sort of adult diets and the risk of developing IBD? Jason Howe's summary of the literature almost a decade ago now is still widely referenced and highlighted the fact that basically people who were consuming a lot of fats, particularly polyunsaturated fatty acids, omega-6 fatty acids, and fat from meat seem to have a higher risk of Crohn's and ulcerative colitis. And if you were consuming more fruits and vegetables, you seem to have a somewhat lower risk. Perhaps more topical today is this question of what's the role of ultra-processed foods in our diet? And this is a really, on the right-hand side of this slide is a lovely study that was just published in BMJ this year that looked at a multinational cohort study followed over an extended period of time. And you can see that those people who consumed more ultra-processed foods had a higher risk of IBD, and particularly Crohn's disease, but also elevated to ulcerative colitis, just to a lesser extent. And then they also broke this down into people who were eating a lot of fried foods. And so fried foods seem to increase the risk of IBD. Interestingly, in this study, they really didn't see much of an association at all for red meat, white meat, or fruits, vegetables, and legumes, although that wasn't as much the focus of this study. Well, that's sort of things that we already think about are maybe not so healthy for us. What about things that maybe are a little more healthy? These data come out of the Nurses' Health Study, where they took people's dietary histories and applied what they referred to as an Empiric dietary inflammatory pattern score. And this is basically a weighted sum of 18 different food groups that are foods that have been associated with having lower inflammatory markers in your serum. And the higher your score, your EDIP score is, the more pro-inflammatory your diet is, and the lower the score, the more anti-inflammatory the diet is. And globally, what they showed was that people who had a higher EDIP score, so were eating more of these pro-inflammatory foods, had a higher risk of going on to develop Crohn's disease, about a 50% higher risk. I think it's interesting to think, though, about, well, can I change my diet? Will that be helpful? And they actually looked at this, and a lot of people's diet goes from less healthy, more healthy to less healthy, and that seemed to be associated with a higher risk of developing Crohn's disease, but not ulcerative colitis. But I think probably the sort of the discouraging side of this study was they also looked at people who went from more inflammatory diet to a less inflammatory diet. And while maybe the risk was a little bit lower, it certainly didn't get the risk back to baseline for Crohn's disease. So, maybe this harkens back to the studies of the immigrants, that some of the damage may already be done and may be hard to revert to actually prevent the disease. But if you were going to try and prevent the disease by dieting, I think the simple answer is to follow what the USDA has told us, and that is that we should all be eating something that in some way resembles a Mediterranean diet. We know it's great for cardiovascular disease. It probably is associated with a lower risk of cancer and neurodegenerative disease. And here are some data that would suggest that it's associated at least with a lower risk of Crohn's disease. And I would just draw your attention to the subgroups of the Mediterranean diet that in particularly seem to be protective. So one are legumes and nuts, which unfortunately Americans eat very little of, but easy advice to patients: if you're going to have something to snack, have some nuts instead of some chips. And the other is the use of olive or rapeseed oil. And again, a sort of easy replacement. Replace for the most part your canola or corn oil with olive oil, and you'll be going in the right direction. So to wrap up this part, what were the implications of this? What you eat and when you eat might influence your risk of developing IBD. Early exposures might be particularly important if we're thinking about preventing the disease. And, the sort of, in air quote, healthier diet seems to be generally associated with lower risk. But I will qualify all of this. These observational studies of diet are very difficult to do. I think they're subject to a lot of variation, which leads to heterogeneity between the results. And some of that's because these are done in different locations, in different populations. The methods of dietary assessment differ, the timing differ. There's issues around maybe unmeasured confounding, and there's certainly, I think, a fair amount of chance for type 1 error in these studies, because often you don't see these studies adjusting for all the multiple comparisons. So you kind of get, here's what comes out, looks good, and you kind of are left with that. More importantly, I don't think this is the question that most patients really care about when they get to see us. They already have IBD. They do care about how to keep their family from getting it, but globally now they have it and they want to know, can I modify my diet in some way to treat my disease? And in general, I think we have 3 ways that we can do this. We can add supplements. That would be the greatest, a little pill, you take it once or twice a day and solves your problems. I'm not going to really speak about that today because we have very little evidence that this works. But if it comes up, we can talk about it in the question and answer session. We can change our diet by taking certain things out and replacing those with more of what we're already eating, or of adding new foods to our diet. And then we can go to this extreme of hugely modified diets if you think about enteral nutritional formulas or parenteral nutrition. And I'm actually going to start there because it has some of the most compelling evidence that diet really has an impact on the disease course, at least for Crohn's disease. Our enteral formulas are all things that you're familiar with: Ensure, Boost, Modulin, Kate Farms, you name it. There's many of them out there. And these meal replacement formulas can have either an elemental, semi-elemental, or polymeric nitrogen source. The fat content is somewhat variable between the different formulations, but the carbohydrates are predominantly glucose, fructose, and sucrose, and most of these have no or minimal fiber content. I think of these as three main different ways that we can use these in clinical practice. The most common, I'm sure all of you do, is just as a caloric supplement for the person who needs to get more calories in. Can you get down 1 or 2 servings of this formula per day? There's then what we refer to as partial enteral nutrition, where we're asking people to really try and get in 50 to 60% of their calories from the formula, and then they'll get the rest from table food. And the most extreme is exclusive enteral nutrition, where we're asking patients to take in 90% or more of their calories from the formula. And most of the research has been on the role of exclusive enteral nutrition. This is an old but still important systematic review and meta-analysis of the studies of exclusive enteral nutrition as therapy for Crohn's disease. And on the left, the forest plot is meant to make one point, which is it doesn't really matter whether you're using an elemental or non-elemental formula in terms of efficacy. You can see the pooled estimate was right at 1. There's no more equal than that. What matters is that the elemental formulas aren't palatable. They don't taste good, whereas you can use a polymeric formula that people can easily drink. And that's a way to sort of get past that barrier of thinking, oh, I have to use an NG tube or a feeding tube if I'm going to administer exclusive enteral nutrition. This can actually be done by mouth for a motivated patient using a polymeric formula. The middle figure on this slide highlights the remission rates with exclusive enteral nutrition in the same studies. So the blue bars are elemental, the red bars are non-elemental formulas. And I just want to highlight these 70% remission rates. Now, admittedly, these studies were done a long time ago before the modern design of clinical trials. But we don't have any drugs that achieve a 70% remission rate. If we did, it would be the ultimate blockbuster drug that we had, particularly one that has no toxicity. So this in and of itself is enough to sort of make you believe in nutrition as therapy. And I will point out that clinical trials, placebo-controlled clinical trials that were done around the same time period had very low placebo remission rates relative to what I've shown you for exclusive enteral nutrition. This was a meta-analysis that we did many, many years ago, showing that a pooled estimate of the remission rate with placebo was about 20%, as opposed to around 60 to 70% with these formulas. Now, obviously, you can't really do a placebo-controlled trial of exclusive enteral nutrition. What you can do is you can compare different formulas, but you can't do a placebo-controlled trial because people know how they're getting fed. I'd like to say that that's exclusive enteral nutrition to induce remission, but you should keep it in mind for a few other uses. One of those is in preoperative management of people who are going to have sort of semi-elective surgery for Crohn's disease. There's a fair number of studies now that have shown maybe we can wean people steroids, reduce their remission prior to surgery, leading to potentially shorter surgeries and fewer postoperative complications. And in fact, the recent position statement from ECHO came out and basically said that exclusive enteral nutrition can serve as a bridge to optimize high-risk patients before surgery in Crohn's disease, but acknowledged that we didn't really have any evidence for this for ulcerative colitis. There are some unknowns, like how many calories, how long do you need to do this for? But I think this is worth keeping in mind for the person you'd like to wean down their steroids, their meds aren't working, and they need some nutritional supplementation, but they can actually use their gut. The one other place I want to highlight the potential future role of exclusive enteral nutrition is as an adjunct therapy when people are just starting on therapy. And so these are a number of studies done mostly in Asia that have looked at exclusive enteral nutrition in conjunction with anti-TNF therapy. And consistently, you see that, these studies showed improved efficacy of anti-TNF therapy as a therapy for Crohn's disease when coupled with exclusive enteral nutrition. I'm not trying to convince you that people should stay on exclusive enteral nutrition forever. In fact, I don't think that's a good idea. Eating is a really important part of our existence as social beings. And I think it's important that people get to whole food diets, but this can be a valuable bridge to get people onto their next therapy. All right, as I mentioned, I think it's important that people be eating whole food diets. So I'm going to spend the rest of the time mostly focusing on what do we know about trying to use diets composed of regular table foods as a therapy for patients predominantly with Crohn's disease. And the first thing I'm going to say is that patients are trying this on their own anyway. So they're just looking to us for advice on how to get there. This was a survey that we did almost a decade ago now of a couple thousand patients with IBD. And we broke them up by those who had Crohn's disease, those who had ulcerative colitis, Crohn's disease with an ostomy, and ulcerative colitis with a J pouch. And what we did was we highlighted here foods that people were more likely to say either they made their symptoms worse than making them better, or they made their symptoms better. They were more likely to say it made them better than making them worse. And so at the top are the things that people were more likely to say made their symptoms better. And the ones that stood out here and were statistically significant were yogurt, rice, and at least for people with a pouch, bananas. So if you take home nothing from this, your patients want to know what they should eat when they're not feeling well. Yogurt and rice is a safe recommendation for them. If you look down the table, there's a whole host of things that patients believed made their symptoms worse. Some of them are sort of the usual suspects, spicy foods and leafy vegetables, but there's a whole lot of other stuff in there that are worth thinking about. Milk and red meat and soda and a variety of other things. But interestingly, there was no single food that really stood out. Non-leafy vegetables and spicy foods were at the top, but there was not like there's one that really, really stood out. Now, there have been some clinical trials done of what I'm going to call restriction diets here. Some have put forth that maybe these should be called therapeutic diets, but in any case, these are diets where we're taking things out of someone's regular diet with the hope of a therapeutic benefit. And this was another Cochrane review that was published just recently. And you can see there's a number of different sort of diets that were tried. In fact, they were so heterogeneous, the diets, that the authors made no effort to try and pull these together. The only one of these diets that was studied twice was this low microparticle diet, and none of these, with the exception of this symptom-guided diet, achieved statistical significance, and it was a very small study with very imprecise estimates. And I will just highlight that the Cochrane review pointed out that the quality of these studies was all very low evidence. So not a whole lot you could take from these controlled trials of diets to try and induce remission in Crohn's disease. For maintenance of remission, there were a few more studies. The studies were almost always larger. And here, again, none of the studies that were published at the time of this review were significantly associated with reduced rates of relapse. The good news, however, was that the Cochrane review said that the quality of the evidence was a bit better, and that was warmth to my soul because one of these studies was my own, and I didn't want to be categorized in the very low group. I was happy to at least make it to low quality of evidence. But that was our study of whether a diet of low amounts of red and processed meats would be associated with less symptomatic relapse. And in fact, we could definitely show that people consume less red and processed meats, but there was absolutely no effect on the rate of symptomatic relapse. Well, that was what was published at the time of the Cochrane review. What I'd like to do now is take a little bit of time and walk you through two recent publications that I think are particularly interesting. And the first of these was a study published by Ari Levine that focused on a diet that he's named the Crohn's disease exclusion diet. And his theory here is much along the lines of what I told you about before, that there are lots of things that we consume in a Western diet that one might hypothesize would trigger Crohn's disease. This could be through affecting the microbiome, affecting intestinal permeability, being pro-inflammatory, as we talked about before, and all of this contributing to a more active disease state. And so in his Crohn's disease exclusion diet, the idea is to take out the foods that he hypothesized would be these triggers to Crohn's disease. And this would mean removing animal fat, wheat, dairy, red meats, emulsifiers, maltodextrins, and carrageenans, and interestingly, replacing these with more fruits and vegetables, something that we don't always tell our patients with IBD to be consuming, particularly those with Crohn's disease. And so he's published a number of papers on this diet, but here's I think the most important study that's been done of this diet. So in this study, it included children ages 4 to 18 who had mild to moderate Crohn's disease. And they were randomized to either follow the Crohn's disease exclusion diet or exclusive enteral nutrition for the first 6 weeks. And the nature of the Crohn's disease exclusion diet is in the phase 1 of this diet, people use partial enteral nutrition with the diet. And I should have mentioned on the previous slide, let me go back to this. So you're adding these fruits and vegetables. Key components of this also are chicken, fresh chicken breast that's roasted, and potatoes, and particularly potatoes that are cooked and then cooled and then eaten again, so that cooling process gets you more resistant starch. And then every day you're having bananas and apples as well. Now, there are other foods that you can have, but those are sort of the core foods. So along with those core foods, in phase 1, you're getting about half your calories from a formula. In this case, they used Modulin. And they compared that to 100% of your calories from Modulin in the control arm. And then after week 6, the Modulin was reduced to 25% in both groups. And the Crohn's disease exclusion diet group continued on the selected foods for that diet, whereas the other group was told you can get the rest of your calories from your usual diet. Now, I'm not even going to show you a slide for the primary outcome of this study. The study was designed to ask which diet would be better tolerated. No surprise, in the first 6 weeks, was better tolerated if you could get 50% of your calories from food, even if it was a very limited menu that you were eating from. But there are other much more interesting data that came out of this study. And one of these was, the reduction in symptoms and CRP seen within the Crohn's disease exclusion diet was dramatic, from baseline to week 6. As you can see here, both of these really significant reductions over time. And I showed you before, we know that exclusive enteral nutrition is very effective for induction of remission in Crohn's disease. I didn't show you, but I will tell you it works rather quickly. And you can see here that at week 6, the symptoms and the CRP levels were roughly equal between the two diet arms. But the most interesting data that came out of this trial came at week 12. So now remember, at week 12, the control group has gone back to their regular diet with 25% of their calories from Modulin. And the Crohn's disease exclusion diet is on this specific, whole food diet with 25% of their calories from Modulin. And no matter what definition you applied at week 12, the Crohn's disease exclusion diet was significantly more likely to have patients in remission, whether you use just symptoms and normalization of CRP, or if you used continued sustained remission, meaning at multiple time points, they met the definition of remission. And I would argue to you that this is probably the best data that we have that a whole food diet can effectively, I don't even know if this is induced or sustained remission, because they probably got to remission by week 6 anyway, but really that a whole food diet is an effective therapy for patients with Crohn's disease. The second trial that I want to tell you about is one that we just completed, and we started this at around the same time that RA was starting the Crohn's disease exclusion diet study. And this trial compared the specific carbohydrate diet, which I will tell you more about if you're not familiar with it, to the Mediterranean diet that I highlighted before. And the reason we did this study was that patients were asking for this study to be done. There's a Corey-sponsored network of patients with IBD. It's actually the same group who we did the survey that I showed you beforehand. But in that network, patients are able to sort of post what questions they think are most important. And this question of how should diet be used to treat people with IBD, and particularly was specific carbohydrate diet an effective therapy, was one of the most popular questions that was posed in this forum. So we decided we should try and get an answer to patients for this. So the DINE CD study was set up to compare these two diets. To tell you a little bit more, specific carbohydrate diet is characterized by high intake of unprocessed meats, poultry, fish, shellfish, eggs. You can have most vegetables, you can have most fruits, and there's some legumes that you can have, but there's complete avoidance of grains. There's avoidance of dairy other than some hard cheeses, homemade yogurt made, fermented for 24 hours with the idea being to really, really minimize the amount of lactose that's in there. And I can tell you, like store-bought yogurt probably is fermented for a couple hours. This is a different exercise, making homemade yogurt. And no sweeteners other than honey, if you could tolerate honey. Contrast that to the Mediterranean diet, which has some similarities and differences. It's characterized by high intake of olive oil, again, fruits, vegetables, nuts, but plenty of cereals, moderate intake of fish and poultry and some red wine, and limited intake of red and processed meats and sweets. So some similarities, some differences. Mediterranean diet, much easier to follow on your own than the very restrictive specific carbohydrate diet. And we set this study up as a 12-week parallel group randomized trial. There were 194 people in the trial. These were all people who had mild to moderate symptoms of Crohn's disease and were on stable medications, and really had the sort of standard exclusion criteria. You couldn't be pregnant, couldn't have an ostomy or a known symptomatic stricture. And we did stratified randomization based on whether or not they were on a biologic. Now, here's a schematic of this, and the most important part of this is to emphasize that for the first 6 weeks of the trial, we provided people with all of their food consistent with the diet that they were on. So once a week, they got a delivery of prepared meals, breakfast, lunch, dinner, and 2 snacks per day. And I'm showing you in the picture down here is an example of a specific carbohydrate diet dinner. And the next picture over is what my refrigerator looked like when I tried the diet for a week. So these are all prepared meals that all I had to do was take these out, microwave them, or put them in the oven, and they were ready to eat. Our primary outcome measure was symptomatic remission at week 6. We also looked at data at week 12. We looked at inflammatory markers, calprotectin and CRP, and a variety of other outcome measures, not all of which I'll show to you today. I'm going to skip past this for the sake of time because we already talked about it. So here was the week 6 primary outcome You can see orange are the specific carbohydrate diets, blue are the Mediterranean diet, and you can see that symptomatic remission was essentially identical between the two groups at about 45% for each of them. For those who had an elevated fecal calprotectin, reduction in that fecal calprotectin down to a near normal range and more than 50% occurred in about a third of patients in both groups. And for those who had elevated CRPs, reduction of high sensitivity CRP to under 5 and at least 50% was extremely uncommon. So glass half full, people symptomatically, a lot of them got better. Glass not half full, almost nobody who had elevated CRP had normalization of their CRP. These are the same outcomes at week 12, just to point out that the results are again almost identical, albeit at week 12, not statistically significant. There was a little bit higher fecal calprotectin response in the specific carbohydrate diet group than in the Mediterranean diet group. But again, if you look over to CRP, you can see essentially, only 7 to 10% had normalization of their CRP. And then I just want to point out that not everybody in this trial had confirmed inflammation at screening. We considered confirmed inflammation to be elevated calprotectin, elevated CRP, or for clinical purposes, you had a colonoscopy recently that showed ongoing active inflammation, but it really didn't make any difference. When we stratified the results based on those who did have confirmed evidence of inflammation and those who didn't, symptomatic response was almost identical across all 4 of those groups, and there was no statistically significant interaction. So from this trial, we concluded that both of these diets were well tolerated, despite, again, increased consumption of fruits and vegetables, just like in Crohn's disease exclusion diet, that symptomatic remission was common with both diets, and it really didn't matter whether people had confirmed inflammation prior to randomization. But again, the downside, neither of these diets really had a meaningful proportion of patients who had normalization of their CRP concentration. You may be asking yourself, maybe this is just helping people's symptoms and it's doing nothing for their inflammation. And we have a diet we use all the time to treat people with IBS to improve their symptoms when there's no inflammation. And the low Fodmap diet has also been studied as an alternative for patients with IBD who have symptoms, but where you can't find inflammation. This is just a reminder that if you look at, for example, abdominal pain as a symptom in IBS, low Fodmap is clearly a very effective therapy. And I think we're all at this point fairly comfortable prescribing it. And probably all realize that our patients do better if they have a chance to talk to a dietitian about this, as opposed to the brief counseling we give them in the office. But here's an interesting study that looked at low Fodmap diet in patients with IBD in the absence of inflammation that could be found. And while it was a small trial, I think you can see that if you looked at, patients with adequate relief of their symptoms, it was clearly more common in those with Crohn's disease and ulcerative colitis, or in the pooled groups. Some of this was really improvement in abdominal pain, but globally, this is another tool you should have that, fine, I'm treating this patient with medications for their Crohn's disease. I think I have their inflammation under control. I haven't got them completely symptom-free. This is your friend. Lots of people with IBD have IBS as well. Don't be afraid to use low Fodmap diet. So as we look to the future, I got interested in diet again. I had a little bit of an interest in this when I was a resident. I got interested in it again when the microbiome came around, and I think omics has made diet fashionable again. And part of this is we really need to understand how these diets work. And so I'm just going to take about 5 minutes before we wrap up and talk about just a little bit of work that we've done trying to disentangle of this. And so this is a paper that we published recently about mostly about dietary fiber and the microbiome and metabolome, but there's some interesting data in here that's completely germane to Crohn's disease. So in this study, we randomized healthy volunteers to either follow a Western-style omnivore diet, exclusive enteronutrition, or we took 10 vegans and they just continued on their vegan diet. And it's a long, complicated study where we had them as an inpatient, the people who were not vegans. We had them on the diet for 5 days, then we wiped out their gut microbiome and they continued the diet, and we looked to see what came back after that. But I'm gonna focus first just on the first 5 days when people were just on the diet. So this is a summary of their gut microbiome, the fecal microbiome, and every dot represents an individual's microbiome on a given day. The colors tell you what day it is. And the arrows in the middle are the sort of movement of the centroid. You can think of this as sort of the average of somebody's microbiome on a given day. And I'll just point out the omnivores who stayed on an omnivore diet and the vegans who stayed on a vegan diet, their microbiome did not move at all. But the healthy controls who we put on exclusive animal nutrition for just 5 days had this dramatic shift in their microbiome. So people have hypothesized that, you know, changing the microbiome is how exclusive animal nutrition works. I'm not wholly convinced of that because the changes we made in these people's microbiome made it look less like normal. So I'm not entirely convinced that that's the mechanism. We also looked at their metabolome, their fecal metabolome during this, and we looked at it at multiple different time points, that sort of diet phase while they got antibiotics and PEG to clean them out, and then during the recovery phase. Without going into a lot of detail, we gave a 4-digit zip code based on the pattern that happened. So if there was 2 meant no change, 1 it went up, 3 it went down. So if there was no change and then it went down, then it went up, and then it stayed stable for a given metabolite, then it would have a zip code of 2312. And it's important to remember the twos are no change during the diet phase, and the 3s are things that went down during the diet phase. And so here's the sort of summary of all these zip codes of different metabolites, how they behaved, and you can see how many metabolites are over here, and they're color coded. So blues are the exclusive animal nutrition group, red are the omnivore, and green are the vegans. And I just want to highlight for you, first of all, the vegans who stayed on their vegan diet all wound up in the 2 groups. So as you would expected, nothing changed in their metabolome. But the people who had like disappearing metabolites were mostly the people on exclusive animal nutrition. So those are the blue lines down here in the 3 zone, suggesting that maybe there are some metabolites that we're knocking down with exclusive animal nutrition that are the mechanism of action. I think that's worth further investigation. So let me just wrap up to say that, you know, if you're looking for some sort of practical guidance for people, don't forget what you learned in med school. Assess everybody for malnutrition, replete their deficiencies, and then advise people to eat, you know, healthy foods. And the common themes of Mediterranean diet, specific carbohydrate diet, Crohn's disease exclusion diet is you have to buy and cook your own food, and you're not eating a lot of processed food. So tell them to, you know, shop the outside aisle of the grocery store where they can get fresh fruits and vegetables and fresh meats and fish. I think everybody should be using olive oil as their dominant fat. And as I said before, you know, think about mixed nuts as an alternative to snacks and chips and cookies. This is a sort of pictorial of those guidance. When we put this out from IOIBD, we made some distinctions between Crohn's disease and ulcerative colitis. But in all honesty, I think most of these guidances hold true for both of these diets. You know, eat lots of fish and vegetables and fruit, and avoid all those other things that are characteristic of a Western diet. And lastly, you know, if you're considering diet as therapy, I think EEN is a practical alternative to steroids, but use a palatable version so you don't have to use a feeding tube. Recognize that therapeutic diets require a major commitment from your patients, and it's really helpful to partner with a dietitian. And I'm frequently now, based on the results of Ari Levine's study, prescribing Crohn's disease exclusion diet for my patients. Now, that's different from using exclusive nutrition as a bridge between two therapies. If you're using nutrition, though, the treatment goals need to be the same. You need to make people feel better and make their inflammation better. And don't forget that you can use these in conjunction with your regular medical therapy. Lastly, particularly to any house staff who might be there, but this is true to all of us, with every consult that we do in the hospital, as a gastroenterologist, we should give some sort of dietary recommendation. And I would just implore you to avoid iatrogenic malnutrition in your hospitalized patients. If you're interested in this, Sonali Pochaudhary and I wrote this recent review on diet for the hospitalized inpatient. But the real point of this is there's a limited group of people who need to be NPO. There's a limited group of people who need to be TPN, and everybody else should be getting food. So I will just conclude by reminding you, everybody needs to eat. Diet can be an important addition to your armamentarium. We have a lot more evidence for Crohn's disease and ulcerative colitis, which is why I essentially didn't talk about ulcerative colitis tonight. And in the future, I really hope that we're going to understand how exclusive nutrition and maybe Crohn's disease exclusion diet and these other diets work. And that we'll get to a way to leverage that to get either to personalized nutrition or even better to meds that work through the same mechanisms. And again, thank you for inviting me. This is just to acknowledge the many collaborators and funding support that's contributed to this work. And with that, I'm going to stop and hope we have a little bit of time for some questions.
Thank you, Jim. That was a wonderful overview of the most commonly asked question that we get in practice. So it's great to be able to provide those data and all the results that we have, even though it's limited, and especially your study as well. So while we're getting up some questions here, I do have one regarding your recent study comparing the simple carbohydrate diet with the Mediterranean diet. There was a sub-part of your study in your report that talked about the microbiome in these patients, and I noticed that there was really no major differences by the end of your study in both groups. So I wanted to get your thoughts on what you think, if it's not the microbiome and its interaction with the immune system, what is the reasoning behind these diets? Of course, we know, okay, they're healthier in general, but what do you think is that triggering factor that helps reduce the symptoms for these patients?
Yeah, I think, first of all, the microbiome part of this didn't come as a huge surprise to me because we've done some studies of healthy volunteers before where we put people on very different diets, and it's really hard with whole food diet to change somebody's microbiome in a meaningful way. I think when inflammation goes away, you'll see changes in the microbiome, but it's hard to change it with a whole food diet. There's just so much between subject variance, and it's almost like your fingerprint. You just kind of hang out there for the most part. How these diets work, I think, still remains a mystery. I think the concept of what small molecules, what metabolites maybe are being produced by the microbiome as opposed to changing the microbiome may be important. And it's something that I think is worth exploring to see to what extent that may be the driving factor here.
Okay. A question came up regarding your recommendation about olive oil. Do you have any comments on whether one should cook with it? There are some resources online advising against applying high heat to olive oil, alleging that harmful toxins may arise.
I think it's a great question. I always get nervous when I say that olive oil should be the predominant fat because there's someone who's going to ask this question. Here's what I would say. If you think about people who follow a Mediterranean diet, like in the really traditional mode of it, think about people in Spain and other parts of the Mediterranean region, they're using olive oil for everything. They're cooking with it. They're using it as, on their fruits and vegetables, not on their fruits, but on their vegetables and their meats, etc. And so I don't necessarily counsel people not to cook with. I wouldn't be deep frying in it, but I don't think you should be deep frying anyway. It's not designed for that, and it wouldn't work very well. But I try not to make things complicated for people. And so I just tell them, use olive oil as your predominant fat and just stick with it.
Got it. Another question, how would you approach the obese patient in light of these findings?
Well, I think the answer is pretty obvious. If you take people who are eating a traditional American diet and put them on any of these diets, they will probably lose some weight. I will tell you, when I did Crohn's disease exclusion diet, I did specific carbohydrate diet for a week. I definitely dropped a few pounds. We actually got them to up the calories a little more in what we were providing people after that. But, but look, I try and eat a semi-healthy diet, but I have lots of guilty pleasures that don't qualify on these diets. And when you take those calories out of your diet, you lose weight. So I think these people will definitely lose weight. I will also add, there's pretty compelling data for Mediterranean diet for NAFLD. And first of all, there's some new evidence that patients with IBD may be more likely to have NAFLD than the general population. If you have an obese patient with IBD, they would be at the highest risk. So getting them on a Mediterranean diet may have added benefits. And I would say the guidance for most patients with IBD, regardless of whether they're using this as a primary or an adjunct therapy, is just tell them they should be on a Mediterranean diet. You get less heart disease, less fatty liver disease, probably less cancer, probably less neurodegenerative disease, and maybe it will help your Crohn's disease symptoms as well.
Okay. Another question regarding what about the Australian study showing sustained remission in the vegetarian group? Sorry.
Yeah, I think there's nothing wrong with a vegetarian diet. It's not in any way inconsistent with any of these diets that I have talked to you about today. You could be a vegetarian on specific carbohydrate diet. You can be a vegetarian on a Mediterranean diet. You can be a vegetarian on Crohn's disease exclusion diet. In all honesty, having talked to Ari about this, and I hate to speak for somebody else, but like the chicken they just needed a source of protein, but there's plenty of vegetable sources of protein. I think it's a completely reasonable option. Disappointing to me was our study of, low red and processed meat, because what easier recommendation could you give people than just take red meat out of their diet? And at least we could only really study symptomatic remission. We did a little bit of calprotectin in that study, but we didn't see any benefit in Crohn's disease. I'd love to sort of redo that study in ulcerative colitis, but time will tell.
I know we're getting close to time, so I'm going to see if we can get some more of these questions answered. Despite lack of quality data on additional therapy, can you comment on the use of probiotics in supplementing gut health for IBD patients?
Yeah, really good question. I said I wasn't going to talk about the pill that solves everything. There are some data, for example, of VSL-3 for patients with ulcerative colitis. It's mostly in combination with mesalamine in some studies that I think were done mostly in India. If I have somebody who really wants to try a probiotic and has ulcerative colitis, I'd say, sure, why don't you try it in this setting? Certainly in pouchitis, there's some small randomized trials that show the benefit of VSL-3. I think most people's experience in America hasn't been as favorable as the clinical trials were, but I think that's fine. The flip side of this is, in all honesty, I think most probiotics are like tourists. You eat them, they go in, they take a look around your intestines, and they leave, and they don't really set up shop and become functioning part of your microbiome. So I tell people, try it for a little bit, but if it doesn't help, don't keep doing it.
So time for one last question. Any thoughts on short-chain fatty acid from butyrate forming microbiome, preserving enterocytes, and preventing liposomal lipid A from getting past the enteral barrier?
In a word, no. I don't have any real thoughts on that, but it sounds like a great hypothesis. I will add that the short-chain fatty acid story, I think, is not done yet. we're sure they must be good, but in all honesty, I don't know that that's really proven. And I won't say that I created this skepticism, but one of my colleagues has driven this skepticism into me, at least to say that we don't really know the whole story yet.
Jim, this is a wonderful lecture, and to give a formal vote of thanks, I've asked Dr. Carl Schmulin to say a few words.
Thank you for a wonderful lecture, Dr. Lewis. I learned a lot, and I hope everybody out there in Zoom land learned a lot as well. We really appreciate you giving the lecture tonight, and invite everybody for next year's lecture to be announced probably in the next few months. Thank you so much.
Thank you very much. Thank you very much.
Thank you again.
We'll see you in the morning. Don't forget, Dr. Lewis will be with us again tomorrow morning for our Friday morning conference, where he will be grilled on some cases. So we'll see you then, Jim.
Terrified. Okay. See you tomorrow. Everybody have a nice evening.